out of London, Ontario. I practice family medicine, and my other main passion is NP education, mainly teaching and helping nurse practitioners and other clinicians really strengthen diagnostic reasoning skills. And, this is a skill that is really career long, it's lifelong. There's things that I'm learning and refining every day in clinical practice. So, we all have to start somewhere. I'm also really excited to announce the launch of the Diagnostic Reasoning Mastery course through NP Reasoning. It's launching February 1st. So if you haven't taken the first 3 modules, those are free. So you can check that out at npreasoning.com. And there will be a discount code during the launch week. So just watch your emails for that if you think this is something that could benefit your practice. So, a couple quick housekeeping items before I dive in. The session is being recorded, but all participant information will be removed for your privacy and confidentiality. I have no conflicts of interest to declare or financial disclosures. And if you guys have any questions throughout, just pop them into the chat or raise your hand, and I'll do my best to answer as we go along or right at the very end. So, when kind of choosing some core topics for today's webinar, it's difficult, right? Because there's so much to learn when it comes to diagnostic reasoning or learning how to think through patient cases. But I'm going to try to give you some high yield tips and strategies that you can apply to your practice right away. Some of this stuff might be brand new to you, but it also might be something that you're very familiar with. But even these concepts that you're familiar with, I think it's very helpful to kind of continue to revisit them and refine how we're thinking about patient cases. Because truth be told, there's always room for growth when it comes to diagnostic reasoning. So diving into it, so a few key objectives that we'll try to get through all of this afternoon is some tips for building a deeper conceptualization of how we actually build strong differentials and some practical strategies to do so. Second, I'm going to run through how to avoid or at least be aware of some common testing pitfalls that, truth be told, we're all prone to, myself included for sure. And then lastly, just to review some very common cognitive biases that unfortunately we're all prone to in medicine, and some cognitive forcing strategies that we can use very practically in our day-to-day practice to minimize medical errors, recognizing that it's impossible to avoid medical errors altogether, but we definitely can use some metacognition tactics to minimize them as much as possible. So getting right into it, building strong differentials obviously takes a lot of time, a lot of exposure to patient scenarios and reflecting on patient scenarios. But what the experts will tell us is that it's not enough to just see patients, to see more patients. What we have to try to do is attempt to extract as much learning from each case as we can. Because in doing so, that's really how we build stronger neural networks in our brain for different diagnoses and how common diagnoses differ from each other. And what I'll say is, when I started off as an NP student, when I went into that room to assess that patient, I would definitely have a really lengthy, list of differentials, and I wasn't very efficient at, getting to that most likely diagnosis. But with time, with practice, with pattern recognition of illness, we can be way more efficient when we're building differentials and getting through that patient assessment. So, basic question might seem like the simplest thing in the world is, what is a differential diagnosis? Well, I think most of us will recognize that, put simply, it's a list of conditions that we think might explain that patient's presentation. But the more I kind of think about the concept of differentials, the deeper it can get. So it begs the question, right? What constitutes a strong differential? What do we need to include in that differential? So put simply, right, we have to recognize what the more likely conditions could be for a patient presentation. So take an example of, an older adult male with chest pain. What my brain should be going to first is thinking about disease prevalence, right? What are the most common or prevalent conditions in an older male with chest pain? Some things that might show up for us, of course, are things like acute coronary syndrome, maybe severe reflux disease, maybe a costochondritis, and so forth. Second, we all know that we absolutely have to evaluate for those red flag or dangerous conditions, right? Because dangerous conditions are actually pretty prevalent, and we recognize that missing them could be catastrophic for that patient. So again, that example of chest pain, I'd also want to be evaluating for things like a pulmonary embolism or aortic dissection and or an esophageal rupture and so forth. And in our third bucket, which may come up for us, are less likely or less prevalent or rare conditions. But I think the important thing is we don't always have to go rooting or searching for those rare conditions. Again, reflecting on back to when I was, a novice clinician, I have a long list of differentials that I'd go through, and sometimes I'd be evaluating for rare conditions when it's really not always necessary if we have something that's way more likely. So, some general principles to practice by. And again, if you're a nurse educator or a preceptor, these are some key things that you can help your students go through when they're presenting their differentials as well. So, some key principles to remember and reflect on is that when we're thinking about differentials, when we're evaluating that patient, just because something pops up onto our mind doesn't mean that we need to test for it. In that chest pain example, if I'm assessing this gentleman and he's telling me the chest pain is worse with exertion, he has a history of dyslipidemia and hypertension and a family history of heart disease. He's short of breath. He has ECG changes like ST elevations or T wave inversions, and he has elevated troponins. Then I'm really going to be zoning in on an acute coronary syndrome. I don't necessarily need to test for something else that initially came up on my differential because something else just became way more likely. Similar to that train of thought is that just because we think of something really rare, we don't need to test for it. We search for those rare conditions or less prevalent diseases when we haven't really come to a conclusion. We've ruled out common conditions, we've ruled out other red flag conditions. That's the time when we should be testing for things that are less likely or more rare. And then blending into this, I think we always need to balance, the idea behind Occam's razor and Hickham's dictum, right? When we're thinking about differentials and diseases in our patients. So to recap, Occam's razor stipulates that the most likely explanation for a patient's condition is usually the correct one. So if we have a unifying set of signs and symptoms and test results to explain a patient's condition, it's usually right. So take that chest pain example, right? We have some classic signs and symptoms of chest pain, ECG changes, and elevated troponins. It's most likely an acute coronary syndrome. But in contrast to this, Hickham's dictum, so Hickham was someone that reminds us that patients can have as many diseases as they damn well please. That's a direct quote from him from way back in the day. This reminds us that, if we diagnose a patient, but they're coming back to us and, their symptoms are worse or their symptoms aren't getting better or treatment's not working, then we have to remind ourselves that patients can have several diseases accounting for their presentation. So that would be the time to revisit our differential and think about what else could be accounting for their symptoms, what we may have missed. And it's definitely a balancing act with these principles because we always have to be judicious about, over ordering tests and under ordering tests and being as efficient as possible because we're all really busy and we have to see several patients in a day-to-day practice. So another thing to highlight is the importance of helping narrow down our differentials or get to that correct diagnosis by creating a succinct and concrete problem representation by the end of that assessment or even embedding that in your documentation. So to recap, a problem representation is really usually a one-liner, maybe a two-liner review or summary of that patient's presentation, including the key features. So those key features typically include the patient characteristics, right? Their age, their sex, sometimes their ethnicity, the pattern and tempo of illness, so whether that illness is acute or chronic, progressive or improving. And then lastly, the key signs and symptoms of that presentation. So again, going back to that chest pain example, a problem representation that I might use to represent this case is, an older adult male with acute onset chest pain worsened by exertion. He's short of breath. He has history of cardiac disease risk factors, and he has ST elevation and T wave inversion on ECG with elevated troponins. So, what that succinct problem representation does for us is it'll likely paint a picture of a disease that we can recognize. So, acute coronary syndrome, to name one major one. And what that is an illness script. So, illness scripts and problem representations go hand in hand. So, to recap, again, an illness script is basically an organized mental file folder that we each have as unique clinicians, or templates that we have for diseases in our brains. And to be frank, right, and a novice clinician is going to have less developed illness scripts or less illness scripts in general compared with a clinician who's been practicing for 5, 10, 15 years. So these illness scripts are built up in our brains over time through exposure to cases, but also with how much learning we can extract per case. So with that chest pain problem representation, that immediately triggers an illness script that a lot of us will have built up in our minds for acute coronary syndrome. So, and recognizing that illness scripts can either be specific, right, for acute coronary syndrome, or they might represent groups of scripts or groups of illnesses. So take this problem representation, for example, right? A 30-year-old female with chronic and progressive malaise, joint pain, and rash. So for a lot of us, that likely triggers a group of illness scripts for autoimmune or rheumatologic diseases, right? This could be a lupus or a rheumatoid arthritis or maybe a psoriatic arthritis. So that's still very useful because it helps narrow down our differential further to most likely something more autoimmune or inflammatory in nature. So I think if you're an educator out there, sometimes it can really help, just advise the students around creating a problem representation and help them build illness scripts for that problem representation. Another thing that I like to do is that, let's say I see a chest pain presentation with acute coronary syndrome. I like to compare and contrast different illness scripts for chest pain. So what would an aortic dissection look like versus, shingles on the torso versus an esophageal rupture look like? And forcing myself to do this will help build up more robust illness scripts, because it takes re-exposure and re-exposure and re-exposure to all these illness scripts to build them up really solidly in our minds. So moving on from that, I think kind of a good segue is learning how to communicate our differentials and the most likely diagnosis in a succinct way. What I mean by this is that it's really crucial for us to be able to document, but also communicate what our clinical reasoning is behind that case. How did we actually come to that most likely diagnosis? And for a lot of you out there, I'm sure, how many times have we opened up a chart and in the plan section, it just states the diagnosis, but there's not much to back it up, and you're not sure if that person evaluated for some red flag causes. And that can be somewhat frustrating at times if you're the one taking after that patient. And medical legally, if you don't include the things you've thought of, it kind of looks like you didn't think of them at all. So what I like to use is this three-pronged framework. So the most likely, the less likely, and the must not miss or dangerous diagnosis framework. What this means is that when I've assessed that patient, what I like to present is the most likely diagnosis with the evidence to back it up from the history, the physical exam, and other tests if needed. And then I like to present the red flag conditions I've thought of and why I think they're less likely, or how I've ruled them out, or how I plan to rule them out. And then sometimes it's also pertinent to document some less likely conditions that we've thought of and why we think they're less likely. So using a brief example here, let's say we're seeing a young female patient with pelvic pain. So off the hop, there could be several things going on with this patient, right? We might think of gynecological issues like an ovarian cyst or torsion, endometriosis, fibroids, pregnancy, so something red flaggy like an ectopic pregnancy or maybe a miscarriage, or something infectious like a pelvic inflammatory disease or some sort of STI causing issues there. Next bucket, we might think of something in the urinary system, right? So kidney stones, bladder infection, kidney infection. We may think of abdominal issues like appendicitis or IBD. So not an exhaustive list, of course. So on the history, we learned that she's had a missed LMP for 2 weeks. She's had spotting for a week. She doesn't have any GI symptoms or systemic symptoms. She denies any high-risk sexual activity, and there's no urinary symptoms either. So major test result here is a positive beta, right? So there's pregnancy happening, whether it's an ectopic or a miscarriage. Any female patient with pelvic or abdominal pain, we really need to get down to the bottom of this red flag presentation. So exam reveals some left lower quadrant pain with rebound and scant bleeding at the cervix. So let's say I'm working in the emergency department as a clinician and I'm handing off this patient, right? A way to communicate this with the next provider or even through your documentation is to think about the most likely diagnosis and why, the less likely diagnoses you've thought of and why you think they're less likely, and then the must not miss or the dangerous conditions you've thought of and how you plan to rule those out. So for this case, I might be saying, it's a young female patient with acute pelvic pain, a missed LMP with spotting, and a positive beta HCG. That's the problem representation. That's really painting that illness script for an ectopic or something bad going on. So I think it's most likely something like an ectopic, maybe a miscarriage because of those backup points. But I've also thought of, infectious things, urinary things, endometriosis and so forth, but they're less likely because of my history in that physical exam. And then the must not miss conditions we've already mentioned are an ectopic, and pelvic inflammatory disease is something you wouldn't want to miss either. So if you're doing that pelvic exam, that's something that you probably would test for as long as the patient is okay with that. So I find that, when in doubt about summarizing your case or communicating your case, this is often a fail-safe way to think through your reasoning process, because there's been many times where I've gone through this and it's highlighted some gaps in my thinking. Red flag diagnoses I haven't considered, and then I need to go back and reassess that patient. So again, something if you're an educator out there, you might share with your students if you haven't already. And again, a really good kind of medical legal way to safely document and think through those cases. Because even if you were to miss something, if you've thought of it and you've tested for it and things are negative, then that will generally cover you in a legal sense. So key takeaway from this section, like we recognize that a diagnosis and differentials are nonlinear. It's a really complex process that our brains get put through, and things are constantly evolving as new data emerges in a case, right? So there's going to be times where you've diagnosed a patient and then a month later they're coming in and things are worse, and maybe they have a completely different diagnosis. It doesn't necessarily mean that you've missed something or done something wrong in that diagnostic process. It just means that the fact of the matter is that diseases evolve over time, things get worse, patients present with new pieces of data, and that's why, that hypothesis is constantly being challenged and updated. So I think it's, again, good to point out that it's healthy to be comfortable with a certain level of diagnostic uncertainty, because, nothing's ever certain in life, and that means that nothing's ever certain in medicine. So just a reminder that we think in probabilities and not certainties. So we do our very best with the most likely diagnosis or the most probable diagnosis. So jumping right into, this might be familiar to some of you, but the use of diagnostic frameworks to help organize our differentials can be really a powerful tool. So key points here is that I'll run through different frameworks that you can use in your everyday practice, but we use what we individually need. So a framework that works for me might not work for you. We can often combine different diagnostic frameworks for a single presentation. And this is just one way to help you organize differentials, right? Another thing kind of practically to do is that if I'm seeing a complex or an atypical case or a case that I'm just simply less comfortable with, what I'll do is, I'll go home or later on in the day sort of reflect on different frameworks that I can use to approach that problem in the future. So I'll read around that case. It cements kind of new knowledge in my mind about that case. And then the next time I see that patient, I can use this new framework to approach the problem with way more confidence and organization. So to run through four common frameworks that are used for generating differentials, we can think of the systems approach, which is essentially using our brains to think through different bodily systems that could account for that patient's presentation. Next, we can use the mechanisms framework, which essentially is asking ourselves what pathophysiologic, mechanism is going on in this patient? What's going wrong in the body? Third, we can think of the anatomic framework. So essentially asking ourselves what anatomic structure, whether it be, muscles, tendons, ligaments, certain body organ, could be causing this patient's presentation. And last, we're all familiar with using checklists and mnemonics. These can be helpful for thinking broadly about presentations. They can help us remember red flags. They can also help us remember diagnostic criteria for certain things. So quickly running through a couple examples. Let's say for the systems framework, we're seeing an older gentleman with a 3-month history of bilateral pitting edema to the legs. So, initially when I saw this presentation way back in the day, I probably winged it quite a bit. So some random things could have come to my mind, like could this be heart failure or liver disease? But what I did was, I went home, I reflected on the case, and I thought about all the conditions I probably missed when I saw that patient. So what I did was, to embed the bodily systems approach to think about what bodily systems can be causing this pitting edema and how can I apply a stronger approach for a future patient coming in with pitting edema. So for example, we can think of the cardiac system, right? Heart failure or restrictive pericarditis. We can think of the endocrine system, thinking of, severe thyroid disease, Cushing's disease or syndrome, acromegaly. The hepatic system, we're thinking of liver cirrhosis, and the list goes on, right? So having just this general framework can now help me tailor my history and my physical exam with that patient. So thinking of heart failure, right? We might be asking that patient whether they're having orthopnea or paroxysmal nocturnal dyspnea, whether they have a history of heart disease, and so forth. And you can go down and kind of tailor your history and physical exam now that you have these things as top of mind. And again, this is a list, not an exhaustive list, but just because something pops up on that initial differential doesn't mean I need to go testing for it, like lymphedema, for example, or a protein losing enteropathy. If something comes up that's way more likely in my assessment, I'm probably going to stick with that as opposed to assessing for every single possible cause of this pitting edema. Next, touching base on the mechanisms framework, let's say we're seeing a patient with acute low back pain, which is a super prevalent condition in primary care. So using the mechanisms framework, I'm essentially asking what mechanisms or pathophysiological causes can cause back pain. So we think of neurologic mechanisms like cauda equina. We think of infectious mechanisms like an epidural abscess. We think of autoimmune mechanisms like sacroiliitis from ankylosing spondylitis, and that list goes on. So a pretty succinct list that you can use to tailor a pretty efficient history and physical exam. Next, we have the anatomic framework, right, which is exactly how it sounds. I find it's particularly helpful for acute or localized pain presentations, especially if you're a visual person. You can think about what anatomic structures could be implicated in that patient's pain presentation. So again, going back to that chest pain presentation, right? We can think about what anatomic structures within that chest pain area can be causing this issue. So of course, we think of cardiac causes like acute coronary syndrome or valvular disease, maybe pericarditis and aortic dissection. Respiratory structures we can think about are, lung pathology, right? A pulmonary embolism within the vasculature, pneumonia in the lung bases, a pneumothorax, and so forth. The list goes on. Next, very, straightforward here. We have a checklist or mnemonic framework. I find, used in isolation, they're not typically very helpful, but I usually like to combine checklist or mnemonics, mental shortcuts or memory cues that can help me remember things like red flags or diagnostic criteria. There is the Vindicate mnemonic that, a lot of people are familiar with. I typically might use something like the Vindicate mnemonic if I'm going through a case, I'm completely stumped, I don't know what it could be, I don't know where to, revisit that diagnostic pathway. Using something like Vindicate can help me think very broadly, right? About could it be a vascular mechanism or something infectious, something neoplastic, and it kind of forces my brain to think through those possibilities. And then same with red flags, right? The nifty mnemonic from Core Back Tool is like a very common one to remember the red flags of low back pain, right? Neurologic, infectious, fracture, tumor, inflammatory. I use that one all the time to just help my brain recall the red flags of red back pain that I wouldn't want to miss during that assessment. So again, key takeaways when using diagnostic frameworks, they're not foolproof, but they're a very good tool to help us organize in our brains, different etiologies and different conditions that could be accounting for that patient's condition. So if I'm seeing something that I've never seen before, I'm usually winging it to some extent, but then I can reflect and ground myself in that case by thinking of different diagnostic frameworks that I can use in the future, right? When evaluating a similar case. So you're going to use what ultimately works best for your brain and your memory, as opposed to what might work better for your colleague. So next, I'm going to jump into, how to think about and remind ourselves to how to avoid common testing pitfalls. Because again, this is a huge part of our job is balancing over investigating and under investigating. It's really challenging. So we have to remember, unfortunately, there's no such thing as a perfect test. So it's up to us to interpret whether we can actually trust that test result, right? So a quick recap, we order a test and we can get 4 possible results that we have to detective our way through. So we can get a true positive result, meaning that we're ordering that test, the result comes back as positive and that patient actually has the disease. Okay, great, we've diagnosed it. But we can also get a false positive result, meaning that we order that test, it comes back as positive, but that patient's actually healthy. So the issue with those false positive results is that we can go down, an Alice in Wonderland rabbit hole of chasing more test results, over investigating and causing anxiety, both for us and also in our patients. Third, we might get a true negative result, meaning that we order a test for a disease, it comes back as negative, and that person is healthy. So that's best case scenario. But we can also get false negative results, right? When we order a test in a patient, it comes back as negative, but they actually have that disease. So the issue with false negatives, as we know, is that it can result in false reassurance, delayed diagnosis, and sometimes morbidity and mortality. So recognizing this, anytime we perform a test, a history question, a physical exam maneuver, or when we order labs or diagnostic imaging, we need to be able to detective our way through interpreting that result. So again, how do we navigate these imperfect tests to land on the correct or most likely diagnosis and to avoid missing critical diagnosis or to avoid a delayed diagnosis? So some 3 kind of key or core concepts to think of is that it takes a lot of time and effort and re-exposure, but it's really important to actually understand and apply our core testing characteristics, right? Our sensitivity, our specificity of tests, our positive and negative predictive values, and our positive and negative likelihood ratios. This was something I had a really poor grasp on early in my career. And I've had to do like a lot of digging and reflection and talking with mentors and more experienced clinicians and applying them and reapplying them to patient scenarios to really get more of a firm grasp on what this means and how I can apply this to get to the correct diagnosis. Next, we always have to incorporate our pre-test probability of disease to inform appropriate testing choices, but also to help us interpret negative and positive test results. And last, we always have to remember to ground ourselves in patient context. So, does this result make sense to that person that I just evaluated? So, diving a bit deeper into it, without going too in depth over our test characteristics, a quick recap, right? Our sensitivity and specificity are a test's basically describes a test's accuracy, right? How good a test is at ruling in or ruling out a disease in question. And I'm doing this all the time. If I'm ordering a test for a specific condition and I have no idea how good the sensitivity or specificity is, I'm looking it up, right? I'm pulling up some reasonable articles off of Google or wherever, and I'm just getting a general sense of whether the sensitivity and specificity is low, medium, or high. So it's not about memorizing the statistics or the percentages. It's just about over time developing that intuitive sense of whether a test has strong or poor sensitivity and specificity. Because this will help you determine whether a test result is trustworthy or not, right? For positive and negative predictive values, I find these even more helpful than sensitivity and specificity because they incorporate an individual test's sensitivity and specificity, but it also incorporates disease prevalence, how common the disease is, and it also incorporates our pretest probability. So, thinking of a brief example, let's say you work in a northern community where TB is highly prevalent, and you're assessing a patient with chronic cough, purulent cough, hemoptysis, weight loss, and fevers. Let's say you go ahead and order sputum samples on that patient and they come back as negative for TB. Well, we have to ask ourselves, can I trust this negative test result? Well, I'm working in a highly prevalent area for TB, and this person is classically presenting with signs and symptoms of TB, and my pretest probability of TB was high before I ordered this test. So that's really predictive values in essence. We're relating it back to that patient in front of us and disease prevalence, how common or rare a condition is. And then likelihood ratios come in handy because we recognize how good a test or how a test will either increase disease probability for us or how it will decrease disease probability for us. And some tests really move the needle on increasing the probability of disease, and others don't move the needle at all. So likelihood ratios can come in handy when we're questioning whether a test will be useful in a case or not. So, second, thinking of pretest probability, right? Pretest probability is a really powerful reminder to us of how to interpret test results and also to remind us whether a test should be ordered or not. So, a quick recap, a pretest probability is the likelihood a patient has a disease before any diagnostic test is performed. And as clinicians, we all have different levels of pretest probability. If you have 5 clinicians in a room assessing the same patient, pretest probability will differ. And that's dependent on your experience as a clinician, how often you've seen that patient presentation, context, disease prevalence, where you work, and so forth. So, why pretest probability is important is that it influences our diagnostic decision making. It affects whether more tests are needed, helps us determine which test may be more appropriate than others, and it helps us interpret that test when the results come back. So, briefly illustrating with a case, let's say we have a very common presentation here, a young female with acute onset dysuria and urinary frequency. So they don't have any complicating factors like diabetes or recurrent UTIs or recent catheterization, for example. They're well otherwise, so no fevers, vomiting, CVA tenderness, and so forth. We do a point of care urinalysis, and nitrites and leukocytes are positive. So the most likely diagnosis at this point in time, right, would be an uncomplicated urinary tract infection. So and if I were to stop and pause and ask myself, what's my, pretest probability for a UTI, it would be high right now. Is it high enough? For me, likely, right? I have enough information with this case that I can diagnose an uncomplicated UTI. But what we see a lot of in this classic presentation is, what's next? Should I send off the urinalysis to confirm that there's nitrites or leukocytes? Should I order a urine culture and sensitivity for an uncomplicated UTI? So, whenever you're pausing to ask yourself in a case whether more testing is needed, we can ask ourselves 4 key questions to make sure that we're not falling into common testing pitfalls. So, number one, what is the probability of X disease? Is it low, medium, or high? Again, thinking in estimations, not exact percentages. So, for this UTI presentation, the probability of disease is pretty high right now. And I ask myself, is it high enough? I might estimate it as, 85% probability of a UTI. That's high enough for me to diagnose and treat this UTI. But there's certain diseases that are more dangerous where we're going to need that probability of disease to be way higher, like in the 90 to close to 100 range. Something like, if you're worried about a pulmonary embolism, for example, it wouldn't be good enough to have a probability of 80% for a PE, or sorry, 40% for a PE. We'd need to lower that probability to, let's say, 5% because it's a way more dangerous diagnosis. Using another example, let's say we order a mammogram on a patient and, breast cancer is suspected by the radiologist. Let's say my probability of breast cancer is 85%. That's probably not high to treat, right? With surgery, radiation, or chemotherapy. We'd need to move the needle of probability to close to 99% to initiate those high risk treatments through a breast biopsy, for example. So you can see how probability really matters based on how dangerous that condition is or how serious the treatment might be. And we all have a different level of risk tolerance as clinicians. So some of us might need that probability to be way lower to rule it out or way higher to initiate treatment. Second, you're going to ask yourself, have I reached the treatment threshold? So for this UTI, do I have enough information to initiate antibiotics? And if the answer is yes, then you go ahead and treat and you don't need to order anything more. But if the answer is no, then that's the time to order more tests. Similarly, you're going to ask yourself, will this test or will any test actually change my plan for management? So, will a urine culture and sensitivity for this uncomplicated UTI presentation actually change the antibiotic that I choose? The answer is no, right? So, waiting for that urine CNS, isn't going to really do much, and it's not going to help in my patient's management plan. And then lastly, another thing to ask ourselves is, could ordering that test do more harm than good? So always weighing the risk benefit of ordering that test. So harms can come in physical forms. Of course, if we're doing a procedure, it can cause things like infection, bleeding, risk, scarring, but also those psychological harms that we really have to weigh heavily. So the risk of getting a false positive result, which can lead to a cascade of unnecessary investigations and patient anxiety. So these four questions, I always ask myself when I'm in doubt about where to go next in that diagnostic pathway, whether more tests are needed, can really help ground you and force you to think through that case and order tests more judiciously. And lastly, we've already reflected on this, right? Thinking of patient context. I always like to say, don't take that test result at face value. Don't take a negative as a negative or a positive as a positive. Think back to that patient that you just assessed. Think about how common or rare that disease is. Think about your exam. Think about your history and your physical exam. If everything's pointing towards a certain condition, but you get one negative lab or diagnostic imaging result, don't let that lab or diagnostic imaging result trump everything that you found on your history exam. Really trust the other tests that you've done. Are the results expected, right? What was your pretest probability? If it was really high for a disease and then the test is negative, you have to weigh whether this is a false negative or not based on what you expected and what your initial pretest probability was. And again, do they correlate with the previous test results? And essentially, can you trust this test result? What are those test characteristics? Does it have a strong sensitivity or specificity or predictive values, or is it a pretty weak test for this disease? So briefly running through a case here, let's say a person comes in with colicky, flank pain, hematuria, dysuria, and urgency. They've had a history of kidney stones a year prior, and we know that recurrence of kidney stones is pretty common. They don't have any systemic features. Urinalysis reveals blood and protein, which again might be pointing towards a possible renal colic presentation. Next step we do is order a kidney ureter bladder ultrasound, and it's normal. It's not saying that it has stones. So reflecting back on, interpreting test results and avoiding testing pitfalls, I'm not necessarily going to take this negative test result at face value. I have to think of disease prevalence of kidney stones. I have to think of the sensitivity and specificity of a renal ultrasound to detecting stones. It's actually not good at detecting smaller stones. It can certainly miss smaller stones in the urinary system. And just thinking back to that patient's history and physical exam, the absence of stones doesn't preclude everything else that I've just assessed. So I likely have to go on, if I'm still suspecting renal colic here, ordering something like a CT has stronger test characteristics for identifying stones of any size. So bottom line is, if you're not familiar with the test characteristics, just look it up. Always ground interpretation of results and whether more testing is needed by, stopping and asking yourself what your pretest probability of that disease is, and always bring in that patient context when you're interpreting a negative or positive or normal or abnormal test result. So last section we're going to dive into is just recognizing some really common cognitive biases that we're all prone to in medicine, applying cognitive forcing strategies to minimize medical errors that are associated with these cognitive biases. So what is a cognitive bias? How I like to frame it is through a physician in Canada. His name is Pat Croskery, and he actually describes a cognitive bias as just a cognitive disposition to respond to certain situations. In other words, our brains just respond to certain clinical scenarios based on intuition. It's automatic. It's not something that we're always aware that we're doing. Of course, none of us wants to be biased, but they are innate and unavoidable, unfortunately. We all use mental shortcuts in medicine to get to answers, to solve medical issues. So cognitive biases are just things that we have to be aware of, and we have to use some forcing strategies to minimize them and how much they show up for us. So briefly, some common biases to be aware of. There's something called anchoring bias, where we're given, an initial piece of information, and that disproportionately influences our reasoning and it limits consideration of other possibilities. So, for example, I had a case of a young teenage female, I believe, with urinary symptoms. And, she had dysuria, urgency, frequency. I thought, okay, this is most likely a UTI, right? And so that little bit of information made me anchor onto that UTI diagnosis. I didn't even consider possibilities like a kidney stone, for example. Just didn't even come to my mind. Even though I got a negative culture and sensitivity result, I ended up reordering that CNS because I was really anchoring on that UTI possibility. So anchoring and confirmation bias go hand in hand. Confirmation bias reinforces that anchor diagnosis by weighing supporting data for your suspected diagnosis way more heavily and discounting conflicting evidence or weighing it way more lightly. So in that urinary example I just mentioned, even though the CNS was negative, I kind of discounted it a bit and I favored other supporting data, like, her mom had a history of frequent urinary tract infections and she had a UTI a year ago. But because this patient kept coming back and her symptoms weren't getting better, I eventually consulted a specialist and they said, hey, have you thought of stones? And that's just something I completely didn't think of because I was anchoring onto that initial diagnosis. Third, we have premature closure, which is when our brains just stop gathering information too quickly and we settle a diagnosis early before exploring alternatives. So, quick example from my own personal experience. I was seeing a gentleman with a kind of an itchy, sort of irritative rash on his torso, and he had a long-standing history of eczema. So I said, "Hey, this is probably eczema. Let's just slap some steroids on that rash, right?" So a few days later, he comes back and the rash is worse. The steroid cream hasn't helped at all. And the rash is sort of more blistery and vesicular in nature. So it ended up being a case of shingles, right? I didn't gather enough information. If I had asked more about, do you have a history of shingles? Have you had a flu-like symptoms recently? I would have been able to fully explore other alternatives. Thankfully, still caught early and I was able to treat him. But that's an example of just premature closure, settling on a diagnosis too quickly in that diagnostic pathway. And last, we have the framing effect, which is really important because this often happens between our colleagues when we're communicating a case or when we're documenting a case. So framing happens when the way a case is presented by others biases interpretation of the case and narrows diagnostic thinking to the listener or to the reader. There was an interesting case that I read about that happened in the emergency department. There was a gentleman who came in with severe epigastric or sort of chest pain, and he had a history of severe reflux, and he had actually been in the emerge a month before. He was worked up for a few different things. They had ruled out acute coronary syndrome and some other stuff. And they landed on, this is most likely severe GERD based on your history. They gave him an antacid cocktail and a low dose of morphine, which was completely settling the pain. One clinician, they were handing off this case at shift change, and they said, hey, we have a person with epigastric pain, severe history of GERD. He was in the emerge a month ago. We've given him antacids and some morphine, and he's responding. So that kind of narrows the diagnostic thinking for that listener. They're automatically thinking, okay, this is probably severe GERD, let's move on. But a few hours later, this patient completely decompensated. He was hypotensive and unwell, and it ended up being an aortic dissection. So again, we're going to go, framing effect happens all the time, and I'm going to go through some cognitive forcing strategies briefly to sort of combat this effect. So the good news is that we can always use quick cognitive forcing strategies in everyday practice just by simply asking the question. Questions never hurt when it comes to medicine or diagnoses. So simple question, you're presented a case, you're thinking through a case, and you just ask, what else could this be? Whether it be with a colleague or a mentor or a consultant. Second, a question I love asking is, okay, what is the worst possible diagnosis for this presentation, and have I ruled it out? So in that last case we just talked about, the aortic dissection, when we think about chest pain, aortic dissection is one of the worst case scenarios. And that was something that just hadn't been thought of or ruled out. Third, we can always ask, do I actually have enough evidence to support my conclusion? Or is it very superficial? Right, with my shingles patient, all I had really was that he had a history of eczema and that the rash was mildly itchy and irritative. It's not perhaps enough evidence to support my conclusion and rule out alternatives. And for that framing effect, if you're being presented a case, or even if you're reading through a chart in that assessment and plan section, I always say it's good and healthy, good to have a healthy dose of skepticism. So just respectfully asking, oh, hey, could you prove that to me? Like, how did you get to that conclusion? Like, what were your test results? What's pointing in that direction? And, what other red flag conditions had you thought of, and how were those ruled out? This can be kind of a fail-safe way to even help your colleague or a student kind of reflect on their diagnostic pathway. And you can also say this to yourself as well, just to highlight, gaps in your reasoning process, or maybe some red flags you haven't thought of. And lastly, we can all embed mental checklists or checklists in our documentation to think through, red flag conditions for presentations, like the low back pain, like for chest pain. And then, embedding that most likely, less likely, and must not miss framework when we're communicating a case to a colleague, or if we simply want to review the case in our own minds, or with documentation as well. This is a good way to, again, highlight gaps in our clinical reasoning and our thinking, to help us even point out some cognitive biases that might be getting in the way of our reasoning. And there's a lot of other strategies, but I just find these they can be very brief and embedded easily in day-to-day practice. So I think the key takeaway here is it's good to have an element of metacognition. So recognizing that our brains are not perfect, we're all going to fall into cognitive traps, testing pitfalls. But if we can use some metacognition, so recognizing how our brains work, we can implement strategies and cognitive forcing strategies to minimize those errors getting in the way, and to minimize medical errors for our patients. So whirlwind, I could, talk about diagnostic reasoning for hours and hours. Good news is, if you haven't done the diagnostic reasoning intro course on NP reasoning, you could sign up for that completely free. And the full course, which I'm really excited about, I poured my heart and soul into it, is coming out February 1st. So stay tuned for that. And if you have any questions about this content or future webinars that you're interested in, please contact me anytime. I have a lineup of future webinars coming in 2026 on menopause and emergency medicine cases and other things. So stay tuned for those.